Hello again, everyone. Sorry, we were supposed to have a 10 minutes break, but I think in the interest of time, we'll continue for the next session. And for this session, we'll be talking about symptoms management. And for the first talk in this section, I will invite Dr. Aaron Hiew, palliative medicine consultant from Hospital Kuala Lumpur, to the stage. Dr. Aaron graduated from University Kebangsaan Malaysia, UKM, and completed his MRCP qualification in 2010. He is currently working in Hospital Kuala Lumpur as a palliative consultant, and he will be giving us all updates on cancer pain management. Here's Dr. Aaron, everyone.
I'm not going to go through the whole breadth and length of what cancer pain management is, but I'm just going to highlight a few aspects where things might have changed or a little bit different from when we first started off learning about cancer pain. So in my content, I have four things that I will talk about. The first is the WHO ladder. The second is breakthrough pain. The third is regarding sufficient pain relief. And the fourth is about cannabinoids. Okay, let's go. So general understandings and practices. Let's start off with a case talking about the WHO ladder. So Mr. T is a 54-year-old gentleman. He has metastatic colon cancer, and the pain is over the epigastric region, a dull type of pain. He only complains of pain with a pain score of 3 out of 10. He's not taking any medication for it. Seems like a pretty straightforward case. So, if you were the team that was seeing Mr. T, what medication do you think would be appropriate for Mr. T? Would it be A, fentanyl patch, B, oral morphine, C, oral tramadol 50 milligrams, D, paracetamol 1 gram, or E, celecoxib? I'll give you a moment. So to answer this, we look at the WHO analgesic ladder, which I'm quite sure that everybody is quite familiar with. It is a ladder which is 3 steps. The first step is for those who have pain a score of 1 to 4. Step 2 for those with a pain score 5 and 6. And step 3 for those with more severe pain score of 7 till 10. And as you know, Mr. T complained of pain which was 3 out of 10. So based on this WHO analgesic ladder, he would fall under step 1. So the choice of medication for him would be non-opioids. That includes paracetamol, NSAIDs, COX inhibitors, plus and minus adjuvants. So for those who answered those answers, yep, that's the correct one. Let's carry on. Again, it's the same Mr. T, but now he has worsening pain. His pain is now 6 out of 10. It is not controlled with paracetamol or NSAIDs. So what do we do next? If you were the team seeing him, what would be your choice of medication for him? Would it be A, oral tramadol 50 milligrams, B, oral dihydrocodeine 30 milligrams, otherwise known as DF118? Would it be C, aqueous morphine 5 milligrams, or even transdermal fentanyl patch at 12 micrograms per hour? So once again, we look at the WHO analgesic ladder. Now Mr. T's pain, he complains of pain of 6 out of 10. So this would fall under step 2. He would actually require a weak opioid, such as tramadol or dihydrocodeine. So those who answer that would be correct. However, there is some newer evidence to show that patients with moderate pain secondary to cancer are more likely to respond to low-dose morphine than they are to codeine. So this study calls into question, do we actually need to have a step 2? Do we actually need to try a weak opioid prior to initiating morphine for those with moderate pain? And it's especially telling because this study found that there were no differences in adverse effects between the two groups. So what did this study did was they carried out an international open-label randomized trial, parallel group trial. Um, the eligible patients who had cancer, pain score of more than 4 out of 10 on a 0 to 10 numerical rating scale that required at least step 1, such as paracetamol on the WHO ladder, they were randomized to the control arm using weak opioids, which is recommended as step 2 in the WHO ladder, or they jumped straight to step 3, which was using a strong opioid, and this group was placed in the experimental arm. So the primary outcome of this study was time to stable pain control, which meant 3 consecutive days where the pain score was less or equal to 3. So secondary outcomes included distress, opioid-related side effects and costs, and the primary outcome analysis was intention to treat with a follow-up period of 20 days. So what did they find? 153 patients were randomized, 76 in the control and 77 in the experimental. What they found was there was no statistical significance difference in time to stable pain control. Both arms were similar. The adjusted hazard ratio for the control arm was 1.03, and in the control arm, 38 of these patients, which is 53%, actually needed to change to a strong opioid due to ineffective analgesia. So in conclusion, this trial said that it is some evidence that a two-step regime is a viable alternative for cancer management. So that's something that we can all can think of when we in our practice, that sometimes we may not need to go to a two-step using a weak opioids, but we might want to and those patients that you might want to consider strong opioids straight away, it is not wrong, and it is a viable alternative as shown in this trial. So moving on to my second topic, I'm going to talk a little bit about breakthrough pain, and this time is case B. Using Mr. Tan again, so Mr. T has HCC. He is on aqueous morphine 10 milligrams 4 hourly. He still has breakthrough pain, but the pain score now is up to 8 out of 10. So, you as the team seeing him, what do you think his PRN medication should be? Should it be A. Aqueous morphine 3 milligrams, B. Aqueous morphine 10 milligrams, C. Oral paracetamol, or D. Oral celecoxib? So C and D are the obvious wrong answer. With a pain score of 8 over 10, it's already step 3 in a WHO ladder. And so therefore we are going to use aqueous morphine as his PRN medication. 10B will be the correct answer, where 10 milligrams is the correct dose. 3 milligrams might be a little bit too low to be used as breakthrough PRN medication. Moving forward, Mr. T is now on aqueous morphine 10 milligrams 4 hourly. He still has breakthrough pain, and the pain score is now up to 8 over 10, and the pain happened suddenly. It usually goes away after an hour. So, what should his PRN medication be? Should it be aqueous morphine 3 milligrams, or B. aqueous morphine 10 milligrams, or C and D, which I mentioned in the earlier slide, which is wrong? So again, aqueous morphine 10 milligrams will be the correct answer. But I'm going to take you through to a little bit of the pharmacokinetics of morphine. So this is what happens when someone takes morphine. When they take morphine, as you can see in the graph, the concentration in the body starts to go up, and it hits a maximal concentration level at 1 hour. But it takes up to 4 hours before you see a significant drop. And by the time it washes out, it's over 6 hours. So this is great for those patients who has pain that persists for a longer time. So Mr. T, yep, correctly, we gave him aqueous morphine 10 milligrams. But what he found was the onset was a little bit too slow. It took half an hour before it started to work. And then once the pain improved and the pain got better, he felt drowsy after that because the pain was already quite well controlled. So what is the alternative? What do we do? So over the last few years, there has been something introduced in the market that seems quite useful for this type of condition. Something that works quite fast so that it follows the pain pattern and it doesn't last too long for those people who have pain that don't last very long. So this is what we have in Malaysia. It's the rapid onset fentanyl. So this drug was developed to provide fast analgesia without going through the part antral route. So by bypassing the part antral route, it avoids the first part. It by and also because of the rapid onset of action, this product avoids first pass hepatic metabolism and intestinal digestion. So a trial by Rauk done in 2009, and this drug was first introduced, showed that it was a randomized placebo-controlled study of the fentanyl sublingual tablets. It was done in 131 adult patients with breakthrough cancer pain. The use of this tablet resulted in significant improvement in pain intensity and relief compared to placebo. As you can see from the graph, and over time, the pain relief was better compared to placebo. So Mr. T again, now he's on aqueous morphine, he's on oral morphine 50 milligrams slow release 12 hourly. He's not taking any PRN medication, but he reports a baseline pain of 3 out of 10. And since this is better than before, he tolerates it. So what do we do next? Do we encourage him to use more PRN medications? Do we increase it to 60 milligrams BD of morphine sulfate slow release? That's around a 20% increment. Do we just continue the same since it's not too bad, or do we ask more questions? So this comes to the third part, which is sufficient pain relief. So there was a study by George et al. In 2022 titled Sufficient Pain Relief as a Practical Benchmark in Cancer Pain Management. It was a prospective study of serial pain scores, patient-rated pain relief, and perceived sufficiency of analgesics. Its objective was to evaluate how patient-rated sufficiency of pain relief corresponded to pain scores, pain relief scores, and the felt need for increasing these analgesics. So what they did was they administered this particular questionnaire. It was in a few parts. Part 1 was they asked an open question. How is your pain? Then they followed up by asking for the verbal rating scale. How would you describe your pain in the last 24 hours? Is it no pain, mild, moderate, or severe? 2B, they asked for the numerical rating scale from a scale of 0 to 10, where 0, as we know, is no pain and 10 is the worst pain possible. So asking the patient, what number would you give your pain in the last 24 hours? Question 3A asks about pain relief percentage. They asked the patient, since you first fill out this questionnaire, how much relief have pain treatment or medications provided? Please circle one of the percentages that shows how much relief you have received. So it goes from 0, where there is no relief at all, to 100%, where it's complete relief. 3B checks for pain relief sufficiency rating. So they ask, Please compare your level of pain in the last 24 hours with the severity of pain when you first filled the questionnaire. How would you best describe any reduction in your pain? 1. That very good reduction in pain. Or 2. Sufficient reduction in pain. 3. Some reduction in pain, but definitely not enough. Or no reduction in pain. The fourth question they asked was regarding pain medication sufficiency. Would you like us to increase your pain medication, or is this sufficient? So the answer will be yes, please increase, or no, this is sufficient. So this study showed that from the numerical rating scale, they had an area under the curve of 94.2% against the pain relief rating. So they concluded that this questionnaire actually identified 97.3% of the patients who wanted analgesic increase, and 85 of those who said pain medications were sufficient. So it's something that we could use in our daily practice without it being too cumbersome by just asking a few more questions. The last part I'm going to touch on is a little bit on cannabinoids. Unfortunately, I can't go in too deep with this. I'm just going to go through one or two things that I think is important. So what are cannabinoids and how is it useful for cancer pain? Or is it even useful at all for cancer pain? So we need to know that cannabinoids comes in many forms. There is the plant derivative, which has THC called tetrahydrocannabinol, or CBD, cannabidiol. There's also the synthetic forms, which is nabilon and dronabinol. Why we want to talk about cannabinoids? Because there is a growing excitement among the public and patients with cancers, researchers as well. Last year, it was brought up in the press about cannabinoids, bringing cannabinoids into Malaysia and it be legal to be used. You can easily Google that and read up what's the story behind that. So, but I'm just going to point you towards this particular review. This was done in 2017. It is a systemic, they looked at systemic review. So they wanted to see cannabinoids used in cancer-related pain. And very important, it's about cancer pain. They only found 8 studies, which was of low to moderate quality, which was done from the 1970s to 2014. These studies compared cannabinoids to placebo or codeine and found that it was not possible to demonstrate a clear therapeutic benefit. And even those that had some therapeutic effects, they were limited by adverse effects. So in conclusion of this study, they said that there is a paucity of high quality evidence on using cannabinoids to treat cancer-related pain. So therefore, clinicians need to think really, really hard whether is it something that you want to move forward with. In a more recent systemic review and meta-analysis done by Boland, this is in 2020, 5 studies were included in the meta-analysis, which had 1,442 participants. All had a low risk of bias, which was good. But what they found was there was no difference between the cannabinoids and placebo for the difference in the change in average numerical rating scale. So the conclusion of this systemic review and meta-analysis said that studies with a low risk of bias showed that for adults with advanced cancer, the additions of cannabinoids to opiates did not reduce cancer pain. So I hope that this short time that I have, I'm just showing you and pointing out there are certain things that have moved forward and certain things that are still not showing sufficient evidence. These are my references. Thank you very much.
Thank you very much, Dr. Aaron. I apologize that some of you may have some issues with the volume of that video. And like we previously said, most of these videos are pre-recorded. And somehow for this particular video, and maybe for some of the next ones too, there will be some difference whether you're using which type of laptop or other devices to log on. If you are experiencing some problems with your volume, can I suggest using a headphone? Maybe that may help if you have a pair. If you can't, we'll try to help with the volume for some of the other ones. But unfortunately, we can't change much about it at this point. But most of this video will be accessible following this session anyway. I do encourage you to ask questions. We will have a question and answer session following the three lectures in this section. But thank you very much, Dr. Aaron, for just now. We'll move on to the next session very soon.